Hello and welcome to Deconstructing Unconscious Bias in Behavioral Healthcare. Origins of Unconscious Bias, Session 1, brought to you by the Addiction, Mental Health, and Prevention Technology Transfer Centers of HHS Region 2. The development of this training was supported by a grant from the Substance Abuse and Mental Health Services Administration, Center for Substance Abuse Treatment, under the United States Department of Health and Human Services. The contents are solely the responsibility of the presenting technology transfer centers and do not necessarily represent the official views of SAMHSA. The purpose of the Technology Transfer Centers program is to develop and strengthen the specialized behavioral health care and primary health care workforce that provides substance use disorder and mental health prevention, treatment, and recovery support services. Specifically, the TTCs help people and organizations to incorporate effective and evidence-based practices into their prevention, treatment, and recovery services. The Technology Transfer Center network as a whole is comprised of three individual networks: the Addiction Technology Transfer Center, the Mental Health Technology Transfer Center, and the Prevention Technology Transfer Center. Each TTC network, the ATTC, MHTTC, and PTTC, includes 13 grantees. That's comprised of a network coordinating office, national focus area centers, 2 in total, one that serves Native American Indian and Alaskan natives, and the other, the National Hispanic and Latino Center. And then there are 10 regional centers that are aligned with HHS regions that collectively provide services across all 50 states and U.S. territories. Here you'll see a map of the grantees that comprise the technology transfer centers. The actual map of the United States is color-coded and it's also numbered according to the HHS regions. In addition, per region, you will see the specific grantees for the Addiction Technology Transfer Center, color-coded in blue, the Mental Health Technology Transfer Center, color-coded in red, and the Prevention Technology Transfer Center, color-coded in green. These are the actual grantees who manage the project so that you could reach out should you require services from the TTCs. First, I'd like to introduce Ms. Diana Padilla, who is a research project manager at the New York State Psychiatric Institute at Columbia University. Ms. Padilla has over 22 years of public health service, including curriculum development, the conduct of evaluation of substance use disorder treatment programs and problem-solving courts, engagement in chronic disease research and prevention, and the provision of classroom instruction to behavioral health professionals, prevention specialists, and drug court practitioners on behavioral health and recovery support practices. Next, I'd like to introduce Ms. Amy Banco, who has been a full-time lecturer in the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers University since 2017. In addition to providing psychiatric rehabilitation course instruction, Ms. Banco serves as a lead trainer and consultant at the Integrated Employment Institute of Rutgers. Within this role, Ms. Banco facilitates training and technical assistance for mental health practitioners on evidence-based practices that enhance social determinants of health for people with mental health conditions throughout New York and New Jersey. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. The use of affirming language inspires hope and advances recovery. Language matters, words have power, people come first.
Excellent. So thanks everyone for being here this afternoon. Really appreciate your time here. especially for this topic and the related issues that are concerned here that we'll be speaking to here. So the format this afternoon is I'm just going to take a few minutes, not really a long time. I really want to give Amy a lot of time to speak, but I'm going to go over, our format is going to be that I'm going to go over some of the, perhaps some of the statistics that really scope the problem. So let me tell you about how we got here. So everyone, there's a host of different sources, of different factors that have created racial and ethnic disparities. And many of us have been knowing about it and been working with those challenges with folks, with people of color in our settings, but never like the recent pandemic, never like before have we seen those numbers really amplified and with all kinds of rates really increasing. And so that's part of what I'll go over, but that was really kind of part of the, that was the gist of the conversation within the 3 TTCs in Region 2, the Addiction, Mental Health, and Prevention Technology Transfer Centers. And leadership, we're talking about how best we can consider helping the workforce, especially with the current issues. We want to deal with what's going on right now and how we can best support you in your setting and in the capacity you work. So that's how this series kind of came up. So this is a 4-part series and on deconstructing bias and behavioral health care. So these are the 3 disciplines we focus on with the addiction, mental health, and prevention. And so the idea is to review what unconscious bias is, where it comes from, and Amy's going to do a great job of going through it with you. So it was, and then we'll provide you with, and how it affects the work we do, and what we should look for, what we should consider. And we'll also provide you with some tools and some strategies that you can incorporate to be able to identify and address hidden bias and some other culturally informed interventions and strategies that you can implement in order to sustain that process of remaining kind of on top of what behavior, what our behavior can be when we are so caught up in our routines, when we are doing so much work and helping the communities, and so we can stay self-reflective, so we can stay aware, so we can be responsive. And so that is the idea of the kind of the information that we want to provide you. Also, you can be able to individually in your capacity, be able to affect, quality care, provide quality care for racial and ethnic groups, but collectively, we can make such an impact in how we address the inequities for multicultural groups. So the blueprint for the 4 sessions, they sort of build on each other. This is pretty much it. And we are going to briefly go over some of the inequities and sources of them and some causatory factors. We'll focus on, Amy will take us through unconscious bias and behavioral health settings, how it develops, and more. We're going to go through all these different topics, including the cultural humility in the class. And we're also going to have, towards the last presentation, we're going to have folks, leadership, actually speak to how they've been able to incorporate some of these strategies, some of the interventions to be able to address it in their settings. And that provides you a better opportunity, even folks that you can, not just organizations that you can model, but folks that you can actually reach out to, leadership and colleagues and associates that you can reach out to that can actually support you when you go and further, build your capacity to do this, to address inequities. And so this is specific to different groups. And for this slide is, this is a slide from the report came from the Congressional Research Service. And so what it shows is, first of all, let me tell you, I worked for a long time. A lot of my background is in research. And I worked for a long time realizing that no matter what statistical report you come out with or what research you read, they typically are modest compared to the actual numbers. But it does provide us an idea, characteristics, trends of what we work with, what we are working with. So among the African American and Black population, in terms of adults, more than 47% struggle with illicit substances, almost 68% struggle with alcohol use, almost 50% struggle with both. So what you see is over 2 million are dealing with substance use disorders. Over 16 million are dealing with mental illness, and you still have almost 4 million who are dealing with both substance use disorder and a mental illness. And so the interesting thing is, if that's not enough, is that almost 42% of African Americans, of young adults with a severe mental illness, receive treatment. So that means there's a whole 58% that didn't. So, and here to go to the American Indian, tribal nations, Alaskan natives. What we see here is 1 in 11 or more than 9% struggle with substances and alcohol. And you see more than 22% have a mental illness. And you see also that there's more than 5% of the folks here of these communities that have co-occurring disorders. So in 2014, the American Indian and Alaskan Natives population had the highest suicide rates among other racial, more than other racial and ethnic groups. And for the male population was like 27 per 100,000 people, and female population was almost 9 per 100,000 people. And so the rate of substance use disorders and all related associated issues have actually increased with this population. So with Hispanic, Latino, and Latinx. So what we see here in the numbers, again, I just find them very staggering. With these populations, you see almost 40% have a substance use. More than 77% have an alcohol use problem. 16% struggle with both. So in terms of serious mental illness, you have more than 21, almost 22% of the populations, who have a serious mental illness. And that also speaks, and then you also have a separate number, and they're not all together, but we have a separate number where 3.3% actually have both the substance use and a mental illness. So Hispanics, like 1 in 10 Hispanics tend to have a mental illness and use in the mental health services they tend to go to is not the specialty care that they would require. They tend to go to a general practitioner. So only 1 in 20 actually receive services from an actual mental health specialist. And then one of the things that you probably know is this is one of several groups of cultural groups that do report that poor communication with the health provider actually impacts their capacity or their ability or desire to want to even return. They have problems communicating. It's not, and when it comes to the Hispanic, Latino, Latinx group, it's not just being able to say the same words in English. There's a comprehension issue there. And in terms of the clinical practice, the clinical practice and the ethical requirements of being transparent with your clients, with your patients, to ensure that they understand what you're conveying to them, so they can adhere to what they need to when they do access your services. This is a huge issue. Several studies have shown that bilingual patients are also evaluated very differently when they're interviewed in English. So the responses tend to be English as opposed to when they're interviewed in Spanish. So something to keep in mind. Asian and Native Hawaiians and other Pacific Islanders. So what we see is more than 33% struggle with illicit drug use. My apologies, substances. I'm trying to use current terminology, empowering terminology. Almost 81% struggle with alcohol use. Almost 14% struggle with both. And so what you also see here is that more than 15% of these populations have a serious mental illness. So we are referring here to really high numbers. So people aged over 18 deal with a substance use disorder. They're at 5%. We're talking about more than 15% with mental illness. And then you have the co-occurring disorder population, which is almost 2.5%. So Alaskan, Asian, and Native Hawaiians and other Pacific Islanders are least likely to seek mental health services more than any, are more least likely compared to other racial and ethnic groups. And so what, there's a lot of stigma around seeking services. They are 3 times more likely to access mental health services, less likely to seek services than their white counterparts. And there's a lot of stigma and a lot of, some of the literature refers to denial. What I would say is misunderstanding. Because denial is more of a judgment world, but I would say a judgment term. And so I would say there's a lot of misunderstanding in terms of mental health and their perspective, which is probably another, which is probably based in their own cultural perspectives. So other mental illnesses sometimes within some of these populations can be considered a weakness and a source of shame. And so that can be a huge barrier for them seeking services. So I wanted to show you here. So this is the population just coming off of 2018. And what we see is how over time, the dominant culture of the white population is slowly decreasing and the other communities are actually increasing. And so and I can show you even better with the next slide. And so here's where I want to add just a little bit more. I want you to consider the projections that come out every year from Statista Research and other entities. And again, they typically are modest. Every projection for the last 10 years of the research that I've been looking at has indicated that populations will grow at a certain way, and they tend to, and what actually happens is the numbers actually tend to be superseded. So the US population, by race and ethnicity, by US population is expected to increase to about from what we have right now, it's like 328 million roughly, and it's expected to increase to like 416 million. And by 2060, by that time also, the Asian and Hispanic American populations, which are the fastest growing, have the fastest growing projection, it'll actually speak to that by 2044, the minority population will take over and become the majority of the population. So this is interesting. So what it's saying here, really, that even though the population is growing, and it's also expected that communities of color will increase, and really stressing the urgency to be able to address these disparities in access to care and the quality of care and the inequitable outcomes in terms of mental health or prevention or addiction. Some of the literature and some of the research has been showing that for a lot of communities of color, there have been some research, there's been some studies that have shown that some folks have had better services over time, that some initiatives have worked, and some have had the same, and some have worse access to care. And so if you go from one to the other, you'll notice that if you're in an impoverished community, if you're from an impoverished, and we think about social determinants when it comes to this, poor versus high income folks, everything in red says that it's worse, that the folks who are impoverished have a much worse access to care. And this is just saying to care. It's not even really speaking to the quality of care. And we even go down the line, because Black versus white population, you'll see is almost half and half. There's been some improvement, but yet there's a huge amount that has still yet to improve. The Asian and the white population, we actually see that there is better improvement between the Asian and white population. They are all the same, but in some instances they're worse. Between American Indian, tribal nations, and Alaskan natives, it's actually been the same, which has not been for the most part, poor access to care, or in a lot of instances where it has just gotten worse. When we go all the way, and these, when we think about when we think about the Native Hawaiian and Pacific Islanders versus white population, it has stayed the same. And Hispanic versus non-Hispanic white, huge amount, very comparable to the first graph slide that shows it's gotten much worse. And so I think some of us are familiar with this as well about the social determinants. These are the conditions that in places that people, are born into, or they live in, or they learn and they work in, and this is where their lives are at. And it affects a range of health and quality of life risks and outcomes. And so the economic status of many folks, and we saw the other graph, was talking about how the impoverished community really had the worst access to healthcare as anyone else, as any other group. And so it's because so many of these components actually have intersections with one another for a lot of these members in these communities. So you want to consider that economic status, neighborhood, physical environment, education, access to healthy food. So I'm certainly speaking about, I'm contrasting, I'm talking about McDonald's and Burger King and the franchises down the block, talking about the ability to have access, or they have the access to healthy foods that are non-franchised, that are farm items, and that tends to be minimal in certain communities, in certain demographic areas. So the community social context, the healthcare system, if you consider all of these determinants, they affect outcomes, they affect life expectancies, they affect health, they affect a person's ability to function. It affects morbidity and mortality. In terms of contributing factors to behavioral health disparities, so what we're thinking here is, what we're considering here is that structural inequities and social determinants of health, including all the components that I had just mentioned, and their personal behavior, meaning their health-seeking behavior. There are a lot of folks that if the priority is to have food on the table and keep a job and pay the bills to keep roof over their head and over the family's head, then the health-seeking behavior is not necessarily the priority. So you can understand, especially you folks who work in the field, you can understand how a lot of these different dynamics can play out. Historically, the groups that are impacted are racial and ethnic populations, people with limited English, LGBTQ plus communities, people with disabilities, and we can mention a few more. So I also wanted to ask, so what I showed you before were some numbers that had really to do with some of the disparity rates, and we had an idea of some of that before. Those were more current numbers. Maybe you didn't know how prominent these numbers have become. But if that's not enough, so I mentioned the pandemic before and how it has really exacerbated access to care or quality care. But it was just to add to this, the latest available COVID-19 mortality rate for Black Americans is 2.5 times higher than the rate for Latinos, which is 2.5 times higher than the rate for Asians, and certainly 2.7 times higher than the rate for whites. So and we've seen that the cultural groups that have been impacted the most by the current pandemic has been the Black and African American communities, and the Hispanic Latino communities. But depending on the region of where you're coming from and where you're at, what you'll notice is that your folks, the tribal nations, the American Indians, may be the one with the highest rates. It might be the Asian population. It really depends on your region, but what we all can understand is that the communities of color are really, they're the ones who are burdened with the biggest impact of the COVID. So barriers to culturally appropriate care. And this kind of speaks to what direction we're going to with these sessions and why we think it's so important to discuss this with you. Think about what we can do as practitioners in our capacity, in our setting. Sometimes, you can look at the structural inequities and decades and decades and, or hundreds of years of systemic issues, And it can almost be overwhelming. But if we start to consider what can we do within our capacity, in our practice, each individual person, each individual professional on this platform who's attending this right now can start to consider what to look for, how we can help, how you can help and elevate your current level of proficiency. And collectively, we can have such an impact on those inequitable, those outcomes for racial and ethnic minorities, those populations that we work with. So these are the barriers that we are going to start to address. I'm going to bypass the first one because that's what we're going to talk about here. So, but we're also going to address systems of care fully designed for diverse populations. I kind of spoke to that, and we've been knowing that. And so language barriers, patient-client fears and distrust, and stigma and discrimination. You might start to consider that there is impact or intersectionality between all of these. Poor cross-cultural communication between their providers and their patients. And certainly the lack of diversity within the healthcare leadership and the workforce, and that's across the nation. That's not just here on the East Coast. And so I bolded the first bullet because that is really the core of what we're doing here today. And we're on unconscious bias. I would like to just turn it over to Amy, who's gonna go through the unconscious bias portion of this presentation.
So we just reviewed some very disheartening statistics on the experiences of Black, African American, American Indians, and Alaskan Natives, Hispanic, Latino, Latinx, and Asian Pacific Islanders when utilizing behavioral health services. It's important as practitioners to identify the sources of these disparities so that we can address it. One of our charges as a counselor, social worker, psychologist, or other practitioner is to be an advocate or a change agent, to disrupt the system and reimagine it or rebuild it, especially if it is barring access for people, if it's compromising quality of service or causing harm. So where do these disparities originate and how are they sustained? One, disparities can be a result of system function or dysfunction, which include things like cost and funding, accessibility, or policies and procedures. Two, disparities can occur and be sustained within the context of how a person experiences service and care. And three, and this is a time for us to look inward as practitioners. Clinicians' perspectives can interact with differences in a person served or client's values and attitudes to shape that person's healthcare choices and unfortunately perpetuate disparities. Disparities in care therefore emerge from the characteristics of the mental health service system or the operation of the healthcare system, as well as from the process of care or factors emerging from the provider, person served, or client interactions. When we consider the perspective in care, both parties are attempting to enter this therapeutic alliance, and they each have their own values, preferences, beliefs, attitudes, which are bathed in our cultural perspectives or norms. And it's important to acknowledge, even as clinicians, that people tend to gravitate towards this idea of ethnocentrism, or the judging of others and their culture using our own culture traits as a point of reference or a standard. So these varied perspectives that we have to traverse in the clinical setting, where do they come from? They're deeply embedded in us and are a result of years of conditioning. Social conditioning begins at birth and continues throughout the duration of our lives, impacting our values, beliefs, behavior, and gets filtered through our lens as a practitioner, inadvertently impacting our role as a clinician and the services that we offer. Let's take a closer look at the process of conditioning through the cycle of socialization. So the cycle of socialization was created by Bonnie Harrow, and it's something that I like to utilize in talking about conditioning and this concept of bias. If you look at the blue section, our socialization begins before we are born, with no choice on our part. These identities are ascribed to us at birth. Therefore, the first step in socialization process is outside of our control. On top of this, we're born into a world where there are mechanisms, assumptions, rules, roles, and bias already in place and functioning. We have had nothing to do with constructing them. The characteristics of this system was built long before we ever existed, based upon history, habit, tradition, patterns of belief, bias, prejudice, stereotypes, and myths. Dominant groups are considered the norm around which assumptions or bias are built, and these groups receive attention and recognition. Dominant groups have relatively more social power. Dominant groups include men, white people, middle and upper class people, able-bodied people, and heterosexual people, as well as those who are cisgendered. Take a look at the green arrow. Immediately upon our birth, we begin to get socialized by the people we love and trust the most. Our families or the adults who are raising us. They shape our self-concept, our self-perception, the norms or rules that we must follow, and they tell us how to behave. This socialization happens both intrapersonally, how we think about ourselves, and interpersonally, how we relate to others. Take a look at the yellow circle of reinforcement of these learnings. Once we begin to attend school, to go to places of worship, see doctors, play on a sports team, or even learn about the legal system, our socialization sources are rapidly multiplied. Most of the messages we receive through these other institutions will reinforce what we learned at home. And if they do not, we then may be cut off from these sources for contradicting these learnings. If we are members of the dominant group that benefit from the rules, we may not notice that they aren't fair. If we are members of the other groups that are penalized by the rules, we may have a constant feeling of discomfort. We learn that these rules, these roles, and bias is larger than just our families. We get consistent similar messages from so many other sources, it's hard to not believe what we are learning. We are actually inundated with unquestioned bias and stereotypical messages that shape how we think and what we believe about ourselves and others. This bias brainwashing is even more insidious because it is woven into every structural thread of the fabric of our culture. Take a look at the orange arrow. It might seem logical to ask why people don't just begin to think independently if they don't like what they're seeing around them. Why don't we ignore these messages if we're uncomfortable with them, or even worse, if they're hurting us? Largely, we don't ignore these messages, these rules, these roles or structures and assumptions because they are enforced and placed in places to maintain them. Take a look at the red circle. It is not surprising that the results of this systematic learning are devastating to all involved. If we're examining those outside of the dominant group, we may experience anger, a sense of being silenced, low self-esteem, high levels of distress, and a sense of hopelessness or disempowerment. It's important to note as I'm going over this, you can be a part of a particular dominant group, and you could be a part of a group outside of the dominant group. For example, I identify as white, dominant group, but I also identify as queer, that is outside the dominant group. And I'm also an individual with a non-apparent disability outside the dominant group. If we are a part of the dominant group, we may experience guilt from unearned privilege or oppressive acts, tendency to collude in the system to be self-protective, high levels of stress, loss of contact with those outside of the dominant group, a sense of distorted reality about how the world is, and obliviousness to the damage we do. By participating in these roles, remaining unconscious of the cycle or disinterest to interrupting the cycle, we perpetuate bias and disparities or inequity for those outside of the dominant group. Take a look at the action section. When we arrive at the result of this terrible cycle, we face the decision of what to do next. It's easiest to do nothing and simply allow this to perpetuate and keep the status quo. We may choose not to make waves, to stay in our familiar patterns. We may say, what can I do to change this? But what we're failing to realize is that we have become participants in this cycle just by doing nothing. This cycle has a life of its own. It doesn't need our active support. It has its own centrifugal force. Our silence is consent to perpetuating unconscious bias and inadvertently health disparities. This cycle is fueled by a core of misinformation, ignorance, and bias. So let's take a look further at bias and get a sense of what that is. A bias is a tendency or inclination or prejudice toward or against something or someone. Bias aims to help us navigate a complex world by processing information quicker. We all have bias. They occur naturally, but that does not mean that bias do not have consequences. Therefore, it is part of our due diligence as practitioners, as counselors, as social workers, to know our own bias and the impact that they can have on our colleagues and the people that we are serving in the clinical setting. And that can be quite challenging. It can be challenging because some of the most consequential bias are ones that are unconscious because they inadvertently lead us to do things that we would vehemently be against otherwise. To make the point, I'm going to use the analogy of blind spots in our car. We all can agree blind spots exist, but how do we define that term blind spot? For me, if I were teaching my son how to drive and discussing what a blind spot is, that blind spot is an area in my car where I'm not easily able to see other drivers. I know they're there, but I cannot see them. We all know that blind spots exist, and we all take extra precautions to ensure we can navigate safely with that blind spot in mind. Well, we also have blind spots in our relationships and exchanges with others, often called implicit or unconscious biases. Unconscious bias are the attitudes, stereotypes that affect our understanding, actions, and decisions on a subconscious level. This means that we have preferences towards certain people. It also means that we may hold negative beliefs about others in ways that we're not actively thinking about or aware of. One of the most well-known bias is the affinity bias, where this bias simply states that we gravitate or give preferential treatment to the people within our own cultural groups. As healthcare providers, our bias may predict our behavior more than we realize. When these biases remain unchecked, they can really impact our interpersonal interactions, and in some cases, even leading to more biased decision-making or unintentionally invalidating the experiences of the people that we are counseling. And at the very worst, do harm by perpetuating health disparities. When our clinical care is laden with bias that harm or disengage people from service, this is a form of institutional trauma or institutional betrayal, which is harm at the hands of those that are supposed to help. This is often in direct contradiction to our ethics our morals, our values as practitioners. Bias and the unconscious mind go hand in hand. We are on autopilot, navigating our day and interactions using automatic cognitive processing. When we get pieces of information, our brain likes to fill in those gaps to assist us in processing the impartial information we're receiving. Schemas are a pattern of thought or behavior that organizes categories of information and the relationships among them. It can also be described as a mental structure of preconceived bias, a framework representing some aspect of the world, or a system of organizing and perceiving new information. We tend to seek out information to reinforce our schemas. That's called confirmation bias. And we disregard information that invalidate or contradict our schemas. Schemas influence what we pay attention to. Schemas help simplify our world, right? By new information is classified and categorized by comparing new experiences to existing schemas. Schemas allow us to think quickly. Because of existing schemas, people are able to kind of assimilate new information quickly and automatically. Schemas can change how we interpret information. Sometimes when we are receiving new information, we tend to distort or alter the new information to make it fit with what we already know. Schemas can also be remarkably difficult to change. People can cling to their existing schemas even in the face of contradictory information. Various types of schemas include social schemas, how people should behave in social settings or situations. Self-schemas, that is focused on our knowledge of who we are and has to do with our awareness of ourself and our identity. Event schemas are focused on patterns of behavior that should be followed for certain events, acting much like a script almost, informing us of what we should do in certain situations, how we should act, or what should we say. And person schemas are focused on specific individuals or groups of people. For example, your schema for your friend might include information about their appearance, their behavior, personality, preferences, etc. So schemas categorize people and this person schema based on salient traits such as gender, age, race, etc. And these schemas can be positive, having preferences towards, like we discussed about affinity bias, or they could be negative. Schemas may provide you with information in the clinical setting, while heuristics are associated with how a person makes decisions based on that information. Heuristics are approximate strategies or rules of thumb for decision making and problem solving, but they do not guarantee a correct solution. More specifically, heuristics are usually thought of as shortcuts that allow decisions or solutions to be reached more rapidly and in a condition of incomplete or uncertain information, often because we are not processing all of the information available. Heuristics can be incorrect, result in errors in judgment and decision making, and have significant clinical implications. Heuristics can compromise our commitment to our field, to our morals, our ethics, and values. Heuristics, however, are malleable and can be adjusted using the practice of mindfulness, especially during our clinical decision-making, like treatment planning and case conceptualization. So the take-home message from the second half of the session is bias occurs naturally in an effort to organize a complex world. The cycle of socialization conditions us and reinforces our bias. Since bias and schemas and heuristics are initiated at an unconscious level, and since there is a vast system in place to reinforce them, Deconstructing them and replacing them with more accurate information requires mindfulness, intentional effort, and commitment. Let's learn more about this with the follow-up cycle of liberation, also developed by Bonnie Haro. As people come to a critical level of understanding of unconscious bias, schemas, heuristics, their impact on others, and the role that they play in health disparities, people, counselors, practitioners begin to seek new paths for creating social change and taking themselves towards empowerment and liberation. This awakening to the system begins the process of change. Getting ready. Once we know something, we cannot unknow it. This phase involves consciously dismantling and building aspects of ourselves and our worldviews based on new perspectives. Processes that are central to this phase are introspection, mindfulness, education, and consciousness raising. We become introspective to identify what aspects of our beliefs, attitudes, and behaviors need to be changed as clinicians. We tend to pay attention to and take inventory of our thoughts, language, our counseling practice, our clinical decisions to see if they're consistent with our newly recognized beliefs or if they need to be dismantled. Reaching out. Almost inevitably, as we're getting ready, it becomes necessary for us to seek experiences outside ourselves and to expose ourselves to a wider range of difference than we had before. We need to practice using our skills and tools with others and experiment with expressing our new views, speaking out when we disagree, looking at our organization's policies and procedures or systems level change instead of staying silent. Building community. The interpersonal phase of this liberation process is marked by a change in how we value others and interact with them on a regular basis. It is a phase of building community and consists of two steps: dialoguing with people who are like us for support and dialoguing with people who are different from us for gaining understanding and building coalitions. And this will help to really reinforce the new values, attitudes, perspectives that we are employing in our lives and in our practice and counseling sessions. Coalescing. Having minimized our barriers, joining with allies, and fortifying our resolve, we're ready to move into action. We may take opportunities to organize, to plan, and to advocate. Right? We should all, in our counseling or social work or psychology field, be able to wear that advocacy hat very well. We're gonna, in this particular phase, educate and motivate colleagues and coworkers to explore similar perspectives. We coalesce and discover that we have more power as coalition, and this gives us encouragement and confidence to make changes to our unconscious bias. Maintaining. In order to succeed, change needs to be strengthened, to be monitored, and integrated into our lives and practice. Just like anything new, it needs to be taken care of, learned about, debugged, and modified as needed. So that concludes the end of our session for today.
Thank you so much, Amy. Very amazingly thorough. Thank you. I just want to thank Clyde for being here, and thank you so much, Amy, for being here. And everyone, thanks so much for being here. I hope you come back next week.